Hi, everyone. Welcome to GI Pathology 101. My name is Nina Sanford. I am a GI radiation oncologist at UT Southwestern Dallas, Texas. Why might be doing a GI pathology course? So, I guess for the last, 7 or so years, I've obviously been to a lot of tumor boards, and we have pathologists there who are, of course, critical in helping us diagnose the tumor. I have also noticed that over time, pathology has become a lot more advanced with regards to new markers, new ways of testing. So I think it is super important now, perhaps more than ever, that we really have a basic understanding of the fundamentals of GI pathology. And that is something I realized was missing in my knowledge base. So I wanted to learn more. And we are so lucky to be joined here today by Dr. Suntrea Hammer. She is the chief of gastrointestinal and liver pathology at UT Southwestern. I've already learned so much from her over the past 7 years. So we are going to go through GI pathology by disease subsite. I'm basically going to ask her to teach me pathology like I am a 5-year-old, give or take. For each subtype, we'll talk about basically how the tumor is diagnosed. We'll go over histology, talk a little bit about molecular markers, and then also what we're looking for in resection specimens. So thank you again for joining us.
Yeah, absolutely. Thank you for having me today.
All right, so let's go ahead and get started. So we'll just start with colorectal cancer. Um, these are typically diagnosed with a colonoscopy with biopsy. They're mostly adenocarcinoma, ranging from well to poorly differentiated. I've been told to look for lumens and glands. So maybe just elaborate on that. Here we have a normal um, colon specimen, but maybe talk a little bit about that, the differentiation, before we get into some of the pathology.
Yeah, so I think it's always important to kind of start with a baseline knowledge of what normal histology looks like. And if you can take a look here at this kind of photomicrograph, I don't know if I can actually point.
Yeah, you can.
Okay,
I
thank
can.
you. All right, so what we see here is kind of a normal mucosal biopsy. So we start with some normal epithelium kind of here at the surface. And then what we'll see are these kind of regularly organized test tube shaped colonic crypts that will kind of be evenly dispersed throughout the mucosa. In between these crypts are what we call the lamina propria, which is just kind of the supportive tissue but between the crypts. And you'll see kind of a normal complement of inflammatory cells in here normally. We look for kind of this normal architecture. We want to make sure that we can see the cells kind of lining those crypts and all the nuclei kind of aligned and all about the same size. So basically looking for normalcy. The bottom of the mucosa is going to be delineated here by this light pink strip of smooth muscle, which we call the muscularis mucosae.
Got it.
And then everything kind of below that is submucosa.
Got it. Got it. And
And
this is H&E, right?
this is an
What's
H&E
pink? What's
stain.
purple?
So pink is eosin and purple is hematoxylin.
Got it. Got it. Okay. Perfect. So this is normal. Um, and then I guess it's just
Yeah, so this is just kind of a close-up of that, so you can take a better look at those cells. So they're going to be kind of columnar shaped, so like little rectangles kind of sitting on a basement membrane. Oops, go back. And then all the nuclei are going to be kind of small and oval shaped and kind of aligned along the basal aspect or the bottom part of the cell. At the top part of the cell, you're going to be seeing these little mucin vacuoles. And so that's kind of the normal way epithelium looks within the colon.
and the mucin vacuoles are those kind of light colored
Yeah, these little
blobs,
purple blobs kind of here.
the little light purple.
And just for further clarification too, this surface, what that means is the lumen. So that's going to be actually inside of the colon. So like the luminal surface of the colon inside.
I see. Yeah, because it kind of looks like it's kind of round the other way, but
Yeah.
like the top part is actually inside the.
Yeah.
Okay. Wow. I actually didn't realize that. Okay. So let's go into some pathology now. Explain how this is different from what we were looking at before.
Right. So as we were kind of discussing in the last slide, let me get my arrow back here for you. Um, Normal mucosa is kind of seen down here. So we're going to have those, again, test tube shaped crypts kind of sitting on a basement membrane. As we work our way around, you can see
I
that these
see.
crypts kind of change nature, right? So they're no longer
That's really helpful.
straight. They're kind of forming these little honeycombs type structures, or cribiform is what we call them in pathology terminology. And then it's a lot darker. So if we're looking again at
Hmm.
the bottom of that image, you can kind of see how the cells are a little bit lighter. You can still see kind of that mucin making those little purple circles kind of at the top of the epithelium. And then as we make our way towards the top of this image, again, everything is starting to look dark and disorganized.
That's really helpful. So here, kind of at 3 o'clock is normal, and then as you get backwards to like
1 o'clock.
1 o'clock to 10 o'clock is abnormal, and then maybe at 9 o'clock is normal again. Does that look more?
Well, it's kind of mixed,
It's
kind of
mixed.
on the other side
That's
here.
true. It's a
But
little
you
bit
can say
mixed.
kind of on the top here is what we would call an adenoma. What we're looking for then is kind of extension of that neoplastic epithelium down below our muscularis mucosae, because we know that that is going to be our boundary for the mucosa. And so you can see right here, this is going to be a little bit of that strip of that pink smooth muscle we were looking at. So everything above it would be kind of more of an intramucosal or an adenoma, right? And everything that's extending down below it now is adenocarcinoma.
Huh.
And again,
Okay. So it's
this
this
is kind of
dividing line here.
yeah, exactly.
That's very subtle.
Yeah, it can be
Okay.
very subtle. And again, it's gland forming, so I'll let you know we're dealing with an adenocarcinoma.
Got it. Wow. Okay. Very cool. Okay. So tumor budding, we've heard of that term. We see it on path resection specimens. What does it mean? What can you describe that image?
Yeah, so we look for a number of things when we're looking at invasive adenocarcinoma on a biopsy, right? Because we are looking for the histologic features that kind of either portend a poor prognosis or some kind of increased risk. And so, things would be like kind of the grade of the tumor or the differentiation, lymphovascular invasion. And then there's this thing we call tumor budding. Just in like simplified terms, really what it is are these kind of little micronodules of cells that kind of extend at the interface. So if we skip back one slide here, looking at this tumor, you can see kind of the end of the adenocarcinoma is down here at the bottom of the image, right? So at the bottom of that image, we're going to look for these little tiny nests of tumor cells that are kind of extending down beyond that. And so this is an image from that area. And we're looking for little cells that are like kind of anywhere from 1 to 5 cells. So like here and this little guy here, which are what we refer to as tumor buds. And basically what they are used for is they kind of predict an increased risk for lymph node metastasis. So that's one. So that's the main reason. So it's really helpful if we can comment on it. In this case, like we had a polypectomy specimen, we see that, but we didn't see lymphovascular invasion. You could, reasonably suspect that this patient may be at an increased risk of a lymph node metastasis.
Got it. All right. And then, here we have a picture of moderately and poorly differentiated. If you could just explain how, you can kind of tell one from the other, and also just how often is there heterogeneity in a tumor specimen? How much of the specimen are you testing, either on biopsy or resection? Yeah, because we see these in the path reports, but it's helpful to know
Kind of what
how
we're
you're
doing
getting.
is,
Yeah.
yeah, sure. So basically, we determine differentiation based on the percentage of the tumor that is forming glands. So it can be heterogeneous or it can be homogeneous. But again, we're just looking at the overall percentage. And so as you can see kind of in the left-hand specimen, the majority of the tumor is showing us these kind of little cleared out lumens, right? So most of it is forming these
So
glands.
they're the white
Yeah,
parts?
the white part. So that would be kind of the
I see.
non-cellular part. So here we're having this gland formation. Anything that's between 50 and 95% gland formation would be a moderately differentiated adenocarcinoma.
Which
So
happens to be, I think, most of the,
most
yeah.
of the cases are. On the
Hmm.
right-hand cell or side, in this image, like you can see that the majority of the cells here are tumor cells, but we can really have a hard time picking out any lumen formation. There might be kind of a subtle one right here, but
So
it's
lumen
really
has to be
hard.
like a round sort of
Punched out hole.
punched out, not just like a patch of white. Sort of has
Right.
to be
Yeah,
a,
exactly.
okay.
It's kind of forming a nice, circular structure.
Got it, got it.
And so for this one, we have kind of less than 50% gland formation that would be considered poorly differentiated.
Cool. Okay. And then just these final two for colorectal cancer is sometimes we'll see like a medullary cancer, a mucinous cancer. My understanding is these are not gland forming or maybe a little bit different.
They can be, but they're a little bit
Okay.
different. And so, yeah, when we're thinking of traditional colorectal carcinoma, again, we're grading based on the percent of gland formation. In this case, if we look at the image on the left, this medullary carcinoma, you can see that the majority of this tumor is actually pretty solid. We don't see a lot of gland formation. We do see, if you could see kind of closer up, there are a bunch of little kind of black dots speckled around here. You can think of it
Yeah.
as kind of pepper on toast or something. Those are lymphocytes
Mm.
that are kind of invading the tumor. Okay, and so that's indicative usually of a mismatch repair deficiency.
Got it.
So these tumors, even though they appear kind of poorly differentiated on histology, actually tend to have a better prognosis
Mhm.
overall than, a traditional colorectal carcinoma. They tend to be more associated with things like Lynch syndrome. So, we kind of think of it kind of in that standpoint. And then similarly on the right, we have a mucinous adenocarcinoma. So those are going to be carcinomas that are usually 50% or more going to be these large pools of mucin. So in this
Got it.
case, you can kind of see these large white areas where there's just basically mucin here in the tumor. And then we'll get either glands or small clusters of cells that kind of float within those mucin pools. Okay, so
Got it.
that's the adenocarcinoma. These also tend to be more often associated with Lynch syndrome or IBD-related cancers. And so similarly, you may say that this almost looks like, you know, like, like a lot of gland formation here. And so maybe you would call it like a well-differentiated adenocarcinoma. But again, the prognosis is probably going to be more tied to like the mismatch repair status.
Got it. Okay. Awesome. All right, so let's talk about molecular markers. These are increasingly used. So IHC versus molecular markers. Our IHC, of course, is looking at antibodies that stain to specific antigens or proteins. My understanding is the ones that are usually positive or CDK20, CDX2, and CK7 negative. And then molecular markers, obviously based on mutations, it can be either NGS or targeted. The ones that I believe we almost always test for in stage 4 are these four: KRAS, NRAS, HER2, and BRAF. And then these other ones I've seen, but maybe are not always tested, right?
Right, exactly. And
Okay,
so again, we run the majority of those based on your request, to see whether or not these patients are eligible for certain targeted therapies. But in every new case of colorectal carcinoma, we're going to be staining for these mismatch repair proteins.
yes. So I actually just learned that there are really these three different ways to test for it. So can you describe when you use one versus the other, IHC, PCR versus NGS, how you sort of think about triaging the different tests?
Yeah, so I think for us, practically speaking, basically on most cases of new colorectal carcinoma, we're going to be running the IHC test.
Okay.
Again, that's going to be antibodies detecting the presence or absence of these mismatch repair proteins.
Okay.
And you have them kind of listed out here. What we're looking for in patients that have kind of intact mismatch repair proteins, they're going to have positive nuclear staining, both in the tumor, and you also will see intact staining kind of in the background tissue. Okay, so you always have that background tissue as kind of an internal control.
Got it.
And that's different. So in IHC, we are testing specifically for the presence of those proteins.
Okay.
For PCR, that is a different test. And so basically, what that's looking for is the presence of microsatellite instability.
Right.
So, if we think about what's going on here, basically, we're looking at the body's ability to mismatch or to repair kind of mismatch bases as the DNA is getting replicated. And so, in these MSI testing, what we're doing is we're looking at portions of the DNA that have like these microsatellite repeats. So these
Got it.
very short sequences, maybe ATG, kind of repeated over and over and over again. That's going to be our easiest way to detect whether or not we're having some deficiency in mismatch repair.
Got it.
And so what they're looking for basically loss of appropriate matching between bases and particularly five satellite repeats that they're looking at. So it's a little bit of a different test and it's done in a little bit different way using PCR. The other thing to kind of know about that is for that and NGS, which is kind of a similar mechanism, you need both your normal background tissue
Okay.
and the tumor tissue because you're comparing what's in the tumor tissue to what is in the normal
I see.
background.
I see.
So it actually requires you to kind of have both types of tissue. Whereas with the IHC testing,
You just need to know.
you just need to look at the tumor.
Okay. Yeah. So I feel like what I've seen is a patient will get IHC, and sometimes if there's ambiguity, we'll confirm with PCR
So
or
that's what
NGS.
we tend to do. So like sometimes you can still have, especially if you have kind of a high clinical suspicion that somebody has
Hmm.
Lynch syndrome, for example, you can have people who have mutations in their mismatch repair proteins that still have enough of the intact antigen present that the antibody can still pick it up, right? So there may be a time where we see intact nuclear staining, which
Hmm.
is recognizing a mutated protein, but it's mutated in such a way that the binding site is still basically intact, so the antibody can still recognize it. The other time is sometimes you'll see kind of this heterogeneous staining. So sometimes maybe if the tissue isn't fixed appropriately or it's fixed too long, sometimes
Got
we
it.
can get some abnormalities or if the tissue's old. Sometimes we can get these abnormalities where maybe the stain isn't working appropriately. And we can use this MSI as kind of a secondary check to make sure, that we're catching all the cases.
Cool. So this is obviously an example of staining.
Yes. And so this kind of shows you,
Here.
oh, thanks. Um, So this is an example where basically here I can tell that this is tumor just based on kind of the disorganization of the nuclei here.
Right, right.
But you can see that we have intact staining here for our different mismatch or pair proteins. And if we're looking carefully at these kind of inflammatory cells in the background, you can see that those are also staining. On the opposite end here, you can see the loss of staining. So here again,
Got
we
it.
have kind of these tumor nuclei and they're negative. But if we look at our kind of background inflammatory cells, you can see they're
I
staining.
see, I
So
see.
we know the stain worked in this case, but it's just that the tumor is
I
negative.
see. So these are presumably talked about in the four proteins, and
Yeah.
they're missing all four, this example.
Well, in this
Well,
example,
maybe some light for two of them.
exactly, yeah.
Got it.
And so you have to remember too that these exist kind of as dimers. So if you lose
I
one
see.
of a pair, like you'll kind of lose, a lot of times you'll lose staining of the other as well.
Got it. Okay. So yeah, what I really want to talk about also is the resection specimen. Always very important for colorectal cancers, rectal cancers in determining the margins, need for adjuvant therapy. So I took what you put in the pathology reports and listed them here, but maybe if you could just walk us through the steps you take when you look at a specimen, both macroscopically and microscopically, and maybe explain some of the terms like tumor deposits, treatment effect, and like go over the different margins. That'd be really helpful.
Sure, sure. So I guess in a sense, what you have here in this image is a rectal resection. And so those are a little bit different than our, other colorectal
Yeah.
carcinoma samples, right? Because a lot of these patients are receiving therapy prior to actually
Hmm.
getting the resection. Um, The other thing that we have to do is we have to be very careful when we look at these specimens. So we know that they have treatment, and that kind of changes the way that the tumor will look. So it
I
definitely
see.
can shrink the tumor down. It can make it look kind of maybe like a little white fibrous scar instead of like a nice bulky tumor that we're kind of used to seeing in most colon cancer specimens. In this case, we do have a rectal resection. And you can see that on one end we have a suture. This is going to be our distal end. And you can see that the tissue here is a little bit kind of ragged as we make our way up.
Yeah.
This is kind of the non-peritonealized portion of the rectum, okay?
I see.
Where it becomes shiny,
Interesting. Okay, I didn't realize that.
yeah. So where it becomes shiny, that's the intraperitoneal portion, right? And so this line here represents that peritoneal reflection you heard
Huh.
people kind of
Very.
refer to.
I can see it now, but it's pretty subtle.
Yeah, so it can be pretty
Interesting.
subtle. You can kind of you learn basically how to do it.
Yeah.
And so the surgeons will kind of resect this portion of rectum, and they're trying to get nice bulk. So they want to remove the entirety of that
Right.
mesorectum, right? And anytime that they leave kind of a portion of it back, there's always a risk that you kind of leave residual carcinoma behind. And so part of our job is also to examine that resection once it comes out and make sure that we don't see any defects or any kind of loss of bulk that might suggest that it's an incomplete resection. So that's kind of our first job.
Got it.
Second, of course, we're going to always evaluate kind of the margin. So the distal margin here, we see the suture as well as kind of the proximal margin. And then in some cases, yeah, I think it's not very in some cases, too, you'll receive a little bit of a sigmoid colon resection with it. And so we'll look at the mesocolon resection as well as one of those margins.
Got
So
it.
that's one difference. You might hear like a radial margin will refer to the raw part there of the rectum, whereas the uh,
Mesenteric?
mesenteric margin is going to be, from your sigmoid mesentery.
I see. Okay.
Okay. Once they open this specimen up, that's when we're kind of then looking for the tumor bed. And again, it
So
could
do you
still,
first like cut it lengthwise or like
yeah,
kind
so
of
it
like
varies. Some people may slice it lengthwise. What
okay.
we try to do actually is fix it intact this way. We
Okay.
kind of put formalin soaked gauze inside of the lumen. And then once it's fixed overnight, we kind of slice it kind of like a bread loaf. So that way we can
I see.
mimic what you guys are looking at on MRI and CT
I see.
scan.
Okay, cool.
So we'll slice it that way. And that way we can see where the tumor is, which sections are involved, and we can also see the relation then of that tumor to all
Hmm.
the different areas of the margin.
Got it.
This margin will put surgical ink on. So we can kind of make sure that we keep track of what represents true margin. We're looking at it microscopically. So that's another thing that we do. Again, a lot of times the tumor will really have regressed a lot. And
Yeah.
so all we see is kind of a very subtle scar on the inside. In that case, we're going to submit the entire tumor bed to make sure that we have like a complete pathologic response.
Got it. Got it. Okay. Yeah. So you talked a little about a treatment effect. How you're looking at the number of viable tumor cells essentially, or
Yes, yeah, exactly. And so definitely we can see different types of treatment effect. You can see basically we'll get what looks like a mucinous carcinoma, where all we have is kind of mucin pools left. Sometimes you will see just kind of a few residual cells here or there. Sometimes it really doesn't look like the tumor was treated at all. You just
Hmm.
see, tons of residual carcinoma in the background. And so basically we grade it based on the amount of tumor that's left.
Got it. Great. Super helpful. All right.